All right, so picture this. You're on call, and a patient comes in with a sudden severe headache. Classic subarachnoid hemorrhage, right?
Yeah.
But then the imaging comes back, and there's no aneurysm. Well, that's where things get interesting. Today, we're diving deep into perimesencephalic non-aneurysmal subarachnoid hemorrhage.
PNSAH.
PNSAH for short.
Yeah.
We've got two great sources, a 2022 review article and a more recent literature review from March 2023 to help us unpack this unique brain bleed.
Yeah, it's a condition that can really make you rethink your approach to subarachnoid hemorrhages, especially for neurology residents like yourself.
Exactly, and that's why we're here. We're going to break down what PNSAH is, why it's different from the usual subarachnoid hemorrhage, and most importantly, what you need to know to manage these patients with confidence.
Absolutely. So first things first, let's define what we're dealing with. PNSAH gets its name from its location. The bleeding happens in the subarachnoid space, specifically centered around the midbrain and pons.
So if you're looking at imaging, that's your first clue. The 2022 review is very specific about the criteria the blood needs to be concentrated in that area, maybe extending a bit to nearby cisterns,
Right.
but no massive bleeding into the ventricles or forming a separate hematoma within the brain itself.
And here's the clincher. No aneurysm. That's what sets PNSAH apart from the typical subarachnoid hemorrhage we usually associate with a ruptured aneurysm.
It's like a neurological whodunit, right?
Yeah.
You've got the crime scene, the bleeding, but no obvious culprit.
Exactly. And speaking of investigations, there's been a lot of debate about the best imaging tool for PNSAH. Digital subtraction angiography, or DSA, is the gold standard for detecting aneurysms,
Right,
but it's invasive.
right. And nobody wants to put a patient through an unnecessary procedure.
Yeah.
Thankfully, high-resolution CT angiography, or CTA, is becoming increasingly reliable for ruling out aneurysms, especially in PNSAH cases.
Yeah, the 2022 review highlights a couple of meta-analyses from 2015 and 2019 that support using high-res CTA as a potential first-line imaging tool in PNSAH. If the CTA comes back clean and the clinical picture fits, you can be pretty confident in ruling out an aneurysm.
So, potentially less invasive testing for our patients, that's a win.
Yeah.
But it still leaves us with that big question: if it's not an aneurysm, what is causing these bleeds?
Well, the exact cause is still a bit of a mystery, but there's one prime suspect, the basal vein of Rosenthal, or BVR, as it's known in neurology circles.
The BVR is a major vein that drains blood from deep inside the brain.
Right.
And it just so happens to run right near the midbrain and pons the PNSAH hotspot.
The 2022 review goes into some detail about the different anatomical variations of the BVR, and it seems like those variations might play a role in making the vein more vulnerable to rupture.
So imagine this. Your patient is doing something that increases their intracranial pressure. Maybe they sneeze hard, lift something heavy, or even just strain a bit. That pressure builds up, and if the BVR has one of those vulnerable variations...
It's like a weak spot in a pipe, the pressure gets too high, and boom, a tiny rupture. And you've got a bleed centered right around the midbrain.
It's a compelling theory.
Yeah.
But as both sources point out, actually seeing that venous rupture on imaging is still really challenging.
Yeah.
It's like trying to spot a pinhole leak in a water pipe. You know, it's there, but it's hard to pinpoint the exact location.
It's really hard.
Yeah.
That's one of the big challenges for future research, finding ways to better visualize these tiny ruptures to definitively confirm the cause of PNSAH.
And that's not to say there aren't other possibilities, right? Both sources mention other less common theories, tiny ruptured arteries, or transient microaneurysms that disappear before they can be detected. It's important to keep an open mind.
Absolutely. And for you as neurology residents, this is where your critical thinking skills come into play. Don't just assume every case is a classic PNSAH.
Right.
Always consider those less common causes, especially if the patient's presentation doesn't quite fit the mold.
All right, so we've got the basics down, what PNSAH is, where it happens, and the likely suspect behind the bleeding. But the big question for any resident is, what does this mean for my patients? And this is where things get really interesting, because PNSAH behaves very differently from a typical aneurysmal SAH.
And thankfully, in most cases, that difference is good news for our patients.
So let's break it down. First, the hemorrhage itself. In PNSAH, the bleeding is usually contained within the cistern, which is a lower pressure environment compared to the ventricles or brain tissue itself.
Think of it like a leak in a contained space. The pressure doesn't build up as dramatically, and that means less damage to surrounding brain tissue. In fact, the 2022 review cites studies showing that blood flow in the brain is often better in PNSAH patients compared to those with a typical aneurysmal SAH.
So less pressure, less irritation to the brain, and better overall blood flow.
Right.
That's a good start. Now, what about hydrocephalus? It's a big concern with any subarachnoid hemorrhage.
Right, that buildup of fluid in the brain can cause all sorts of problems. But here's the good news with PNSAH. It's much less common. The blood often settles neatly within the cistern rather than blocking the flow of cerebrospinal fluid.
And even when hydrocephalus does occur in PNSAH, it tends to be less severe and often resolves on its own or with a few lumbar punctures.
Much less invasive than dealing with a shunt, right?
Yeah.
So that's another point in favor of PNSAH.
Okay, now for the big one, vasospasm. It's the complication we all dread with subarachnoid hemorrhage. But with PNSAH, we can breathe a little easier.
Both sources emphasize that vasospasm is less common in PNSAH, and when it does occur, it's often asymptomatic. The amount of blood seems to be the key factor, and thankfully, PNSAH usually involves a smaller bleed compared to aneurysmal SAH.
Remember those Fisher and Hunt-Hess scales we use to grade the severity of subarachnoid hemorrhages?
Yeah.
Well, PNSAH typically scores low on those scales, which translates to a lower risk of vasospasm.
But here's a word of caution. While symptomatic vasospasm is less common, the 2022 review does mention that silent ischemia-reduced blood flow without obvious symptoms can still occur.
So even though PNSAH is generally benign, careful monitoring is still crucial. We need to be on the lookout for any signs of neurological deterioration, even if the patient initially seems to be doing well.
Absolutely. Vigilance is key, especially in those first few days after the bleed.
All right, so let's put it all together. What does a typical PNSAH patient look like? Well, both sources paint a similar picture. It's usually a middle-aged woman presenting with a sudden headache, often described as the worst headache of my life.
And importantly, the other symptoms are often milder compared to a typical aneurysmal. SAH nausea and vomiting are common.
Sure.
But things like a stiff neck, focal neurological deficits or seizures, those are less frequent.
And another big sigh of relief, most PNSAH patients have a normal level of consciousness. You're likely to encounter a patient who is alert, oriented, and primarily complaining of that severe headache. Of course, you'll still do a thorough neurological exam and order the appropriate imaging, but it's reassuring to know that the initial presentation is often less alarming.
Exactly, and that's a good point to transition to the prognosis because when it comes to PNSAH, the outlook is generally excellent.
Both sources are full of good news on this front. The 2022 review reports a 97.2% 13-month survival rate and a whopping 98.6% 30-month survival rate. And get this, there's a study mentioned where no PNSAH-related deaths occurred over 1,213 patient years of follow-up.
That's remarkable. It really highlights how different PNSAH is from its more dangerous cousin aneurysmal SAH.
And it's not just about survival, it's about quality of life. Both sources emphasize that most PNSAH patients regain functional independence and return to their normal lives. They can go back to work, enjoy their hobbies, and live full, active lives.
That's what makes PNSAH so fascinating. It's a brain bleed with a happy ending in most cases.
Exactly. It's a reminder that not all subarachnoid hemorrhages are created equal.
Now, speaking of management, the good news continues. Both sources agree that the best approach for PNSAH is conservative management.
We're talking symptom relief pain management, controlling nausea, and monitoring closely for those potential complications we discussed earlier.
Remember that Triple H therapy we used to use for vasospasm? We'll toss that out the window for PNSAH.
Oh, okay.
The 2022 review makes it clear no need to mess with blood pressure and fluid balance if the risk is low.
It's all about minimizing interventions and letting the body heal itself.
But let's be clear, conservative doesn't mean hands-off. Both sources mention the potential for long-term cognitive and emotional impacts, even in those patients who recover well physically.
The 2022 review highlights issues like fatigue, difficulty returning to work, and even subtle cognitive changes that might linger after the initial bleed.
It's a reminder that rehabilitation is crucial even in seemingly mild cases. We need to support our patients holistically, addressing not just their physical recovery, but also their cognitive and emotional well-being.
So while PNSAH might seem like a good brain bleed, it's important to remember that every patient is unique, and even a seemingly minor bleed can have lasting impacts.
And that brings us to a key takeaway for any neurology resident. The patient is at the center of everything we do. We need to treat the whole person, not just the disease.
Absolutely. It's easy to get caught up in the technical details, the imaging findings, the diagnostic criteria, but we can't forget that behind every scan, every case study, there's a human being whose life has been touched by this condition.
And that human being deserves our compassion, our understanding, and our commitment to providing the best possible care, even when that care involves watchful waiting and supportive therapy.
Well said.
Yeah.
So what have we learned about PNSAH so far? It's a distinct type of brain bleed that usually affects middle-aged women, the hallmark. blood pooling around the midbrain, and pons on imaging without any sign of a ruptured aneurysm. And that's the key to understanding its generally benign nature. Compared to a typical aneurysmal SAH, PNSAH tends to cause less severe symptoms, fewer complications like hydrocephalus and vasospasm, and an overall excellent prognosis for long-term survival and functional recovery. But we're not done yet. There were still some lingering questions about PNSAH, and the 2023 literature review has a particularly interesting detail that might just shed some new light on this mysterious condition.
And this is where things get really exciting, because it turns out there might be another culprit lurking in the shadows.
Ooh, new suspect. Tell me more.
Remember those tiny arteries of Davidoff and Schechter we talked about way back in med school? They're not exactly the stars of the neuroanatomy show.
Okay, you're gonna have to refresh my memory here, Davidoff and Schechter. Those ring a bell.
They're those little vessels that supply blood to the falx cerebri and tentorium, basically the folds of dura mater that divide the brain. Usually they're pretty inconspicuous, but this 2023 review suggests they might play a role in some PNSAH cases.
Now that's interesting. How could these tiny arteries be involved in a brain bleed?
Well, picture this. What if in some patients these arteries aren't just normal arteries? What if they form an abnormal connection with nearby veins, like a tiny arteriovenous malformation?
An AVM. So you're saying that in some PNSAH cases, the bleeding might actually be coming from these tiny AVMs in the dura rather than a ruptured vein.
Exactly. It's a fascinating hypothesis, and it highlights the importance of considering anatomical variations even in the smallest vessels.
Sure.
We tend to focus on the big players, the major arteries and veins, but sometimes those tiny back roads on the neurological map can lead to unexpected destinations.
This is why I love neurology. It's like solving a puzzle. And sometimes the tiniest piece can change the whole picture. So if we connect this back to PNSAH, you're suggesting that it might not be a single entity with one clear cause, but rather a spectrum of presentations with potentially different underlying mechanisms.
Precisely. Some cases might be caused by a ruptured basal vein of Rosenthal, while others might be due to bleeding from these tiny dural AVMs. And there could be other, even rarer causes that we haven't even discovered yet.
Okay, now you're really making me think. So maybe we're not dealing with just one neurological whodunit, but a whole series of mini mysteries, each with its own unique set of clues.
And that's what makes neurology so captivating. There's always more to learn, always another layer to peel back. And as neurology residents, you're in a prime position to contribute to that ongoing exploration.
I'm feeling inspired. So what's the takeaway message for our future neurologists? When you encounter a patient with suspected PNSAH, remember, it's all about careful observation, thorough investigation, and thinking outside the box.
Don't just rely on textbook definitions. Consider those anatomical variations, those less common causes, and the individual patient's unique presentation.
And don't forget, even with the unknowns, we can be confident that we're equipped with the knowledge and skills to approach PNSAH with a sense of understanding and optimism.
Because the good news is, even though the exact cause of PNSAH might still be a bit of a mystery, the prognosis for most patients is excellent. They recover well, they return to their normal lives, and they rarely experience those dreaded complications like vasospasm and hydrocephalus that we see with aneurysmal SAH.
That's definitely something to be optimistic about, and it highlights the importance of accurate diagnosis. If we can confidently identify PNSAH, we can reassure our patients, avoid unnecessary interventions, and focus on supportive care and rehabilitation.
Right, and that's where staying up to date on the latest research comes in. This 2023 review with its intriguing theory about those dural AVMs is a perfect example. It's a reminder that our understanding of PNSAH is still evolving and there's always more to learn.
Exactly. So to all the neurology residents out there, keep those brains engaged. Keep asking questions and keep digging deeper into the fascinating world of neurology.
Because who knows, you might just be the one to solve the next PNSAH mystery.
Now that's a challenge I'm up for. But before we get too carried away with future research, let's bring it back to the here and now. What are some practical tips for managing PNSAH patients in the real world? What are the things that neurology residents should be thinking about when they encounter this condition on the wards or in the clinic?
Well, first and foremost, it's all about recognizing those red flags. A patient comes in with a sudden severe headache, think thunderclap headache, that should always trigger your spidey sense for a possible subarachnoid hemorrhage.
Right. But as we've learned, not all subarachnoid hemorrhages are created equal.
Right.
So how do we distinguish PNSAH from the more typical aneurysmal SAH?
That's where the imaging comes in. Get that head CT or CTA stat. You see blood pooling around the midbrain and pons, and there's no sign of an aneurysm. That's a strong indication of PNSAH.
And remember, those strict diagnostic criteria from the 2022 review are your friends. The bleeding has to be centered in that specific location. No massive ventricular involvement, no intracerebral hematoma. It's all about location, location, location.
Exactly. And once you've got a good suspicion of PNSAH, it's all about careful monitoring and supportive care. As we discussed, these patients usually do very well, but we still need to be vigilant for those potential complications, even if they're rare.
So what does that monitoring look like in practice?
Well, frequent neurological exams are key. We're looking for any signs of deterioration changes in mental status, new focal deficits, anything that suggests the bleed might be expanding or causing other problems.
Right. And of course, we're keeping a close eye on those vital signs, especially blood pressure. Even though the risk of vasospasm is lower in PNSAH, we don't want to miss any subtle signs of trouble.
Exactly. And if there's any doubt, don't hesitate to consult with your senior residents or attending physicians. It's always better to err on the side of caution when it comes to brain bleeds.
So careful monitoring, supportive care, and early consultation if needed. Got it. But what about those long-term cognitive and emotional impacts that the 2022 review mentioned? How do we address those?
That's where a multidisciplinary approach is so important. We need to involve our colleagues in physical medicine and rehabilitation, neuropsychology, and even social work. These patients might need help with things like fatigue management, cognitive rehabilitation, and returning to work.
And don't forget the emotional support. Having a brain bleed, even a benign one like PNSAH, can be a scary and stressful experience. These patients need our empathy and understanding.
Absolutely. And sometimes just listening to their concerns and validating their experience can make a world of difference. Remember, we're not just treating a disease, we're caring for a whole person.
Well said. So it sounds like managing PNSAH is all about combining our knowledge of the condition with a healthy dose of clinical judgment and compassion.
Exactly. And that's what makes neurology such a challenging and rewarding field.
Speaking of rewards, both of those sources we've been discussing highlight another fascinating aspect of PNSAH, the potential for spontaneous recovery. It seems like the body has an incredible ability to heal itself even from brain bleeds.
That's right. And that's something that often surprises even experienced neurologists. We're used to thinking of brain bleeds as catastrophic events that require aggressive interventions, but PNSAH challenges that assumption.
It's like the brain has its own built-in repair system, and in many cases it can handle these small bleeds without our help.
And that's a humbling reminder that sometimes the best medicine is watchful waiting and allowing the body to do its thing.
But of course, watchful waiting doesn't mean doing nothing right. We still need to be vigilant for those rare cases where things might take a turn for the worse.
Absolutely. And that brings us to another important point for neurology residents. Understanding the nuances of prognosis. While most PNSAH patients have an excellent outlook, there are some factors that might increase the risk of complications.
So what are those red flags that we should be on the lookout for?
Well, one thing that both sources mention is the size and location of the bleed. Larger bleeds, or bleeds that extend into certain areas, like the ventricles, might carry a higher risk of complications.
And what about those anatomical variations we talked about earlier? Could they also influence the prognosis?
That's a good question, and one that needs further research. It's possible that certain variations in the basal vein of Rosenthal or those dural arteries might make a patient more susceptible to rebleeding or other problems.
So it sounds like we still have a lot to learn about the prognostic factors in PNSAH.
Absolutely. And that's where those research questions we posed earlier become so important. If we can identify the specific anatomical features or other markers that predict a less favorable outcome, we can tailor our management accordingly and provide even better care for our patients.
Exactly. And that's what makes neurology such an exciting field. There's always something new to discover, always a new puzzle to solve.
And that spirit of discovery is what we hope to inspire in all of you listening.
Well said. Now, before we wrap up our deep dive into PNSAH, there's one more intriguing detail from the 2023 literature review that I think is worth mentioning. It's about a potential link between PNSAH and certain genetic conditions. Genetic conditions. Now that's a new twist. I'm all ears.
It's still early days, but there's some emerging evidence suggesting that certain genetic mutations might predispose individuals to PNSAH.
So it's not just about those anatomical variations we discussed, but also about the underlying genetic code.
Exactly. Think of it like this. Some people might be born with a slightly weaker plumbing system in their brain, making those veins more susceptible to rupture under pressure.
That makes sense. But what kind of genetic conditions are we talking about here?
Well, the 2023 review mentions a few specific genes that have been implicated in PNSAH, including those involved in collagen formation and blood vessel development.
Collagen. Isn't that the stuff that gives our skin its elasticity?
That's right. But collagen is also a crucial component of blood vessel walls, providing strength and structure. So if you have a genetic mutation that affects collagen production, it could potentially weaken the walls of those veins in the brain, making them more prone to rupture.
Wow, that's fascinating. So you're saying that even a seemingly minor genetic glitch could increase someone's risk of PNSAH.
Exactly. It's another piece of the puzzle, and it highlights the complexity of this condition. We're learning that PNSAH isn't just one thing, it's a spectrum of presentations with multiple contributing factors, both anatomical and genetic.
Okay, so if we're thinking about the future of PNSAH research, it sounds like genetic testing might play a bigger role.
Absolutely. As we identify more of these genetic links, it could help us identify individuals who are at higher risk of PNSAH.
And that could potentially lead to earlier diagnosis and maybe even preventative strategies down the road.
It's definitely a possibility. Imagine a future where we can screen for these genetic mutations and offer personalized advice to those at risk, maybe even develop therapies that target those specific genetic pathways.
That's incredible to think about. But for now, I guess the takeaway message for our neurology residents is to be aware of this potential genetic component and keep an eye out for any family history of PNSAH or related conditions.
Exactly. And don't be afraid to ask those questions about family history, even if it seems like a long shot. Sometimes the most unexpected clues can lead to a breakthrough in diagnosis.
Well, I think it's safe to say that we've covered a lot of ground today. We've explored the anatomy, the imaging, the likely causes, the good news about prognosis, and even those lingering mysteries and exciting avenues for future research. What a deep dive this has been.
And hopefully our listeners, those future neurologists out there, are feeling inspired and ready to tackle the challenges of PNSAH with confidence and a healthy dose of curiosity.
I know I am. This has definitely changed the way I think about subarachnoid hemorrhages. Remember, not all brain bleeds are created equal, and sometimes those cases that seem the most puzzling can actually lead to the most fascinating discoveries.
Absolutely, and that's what makes neurology such a captivating field. It's a constant journey of exploration, where even the smallest details can have profound implications.
So to all our listeners out there, keep those brains engaged, keep those questions coming, and keep diving deeper into the amazing world of neurology.
And remember, as you embark on your careers as neurologists, you have the power to make a real difference in the lives of your patients.
Because knowledge is power. The more we understand about conditions like PNSAH, the better equipped we are to diagnose, accurately manage effectively, and offer our patients the best possible care, which in this case often means reassurance, support, and a whole lot of hope.
Beautifully said. I think we've done PNSAH justice today.
I agree. And on that note, it's time to wrap up this deep dive.
Until next time, keep those neurons firing and never stop exploring the mysteries of the brain.
This has been The Deep Dive.